Welcome to this special edition of AIDSWatch. I'm Jesse Milan, President and CEO at AIDS United. You know, it's exactly 6 months since our regular spring edition of AIDSWatch happened back on March 30th. When we transitioned that event to virtual, we knew that our world had already changed dramatically. What we did not know was that in the ensuing 6 months, 200,000 Americans would die from COVID-19, and that we did not know who among them had HIV or were LGBTQ. But we do know now that an overwhelming and disproportionate number of them are Black. When we last convened AIDSWatch, we did not know that Black men and Black women's deaths at the hands of police would ignite a massive call for racial justice. We know their names, but we don't know the names of all the many others who suffer unjust harassment and arrest and incarcerations at the hands of our criminal justice system. And we did not know that our economy would be upended by lockdowns and shutdowns, resulting in so many losing their jobs and homes. And so many of them are our clients and patients and family and friends. And we know their names. What I did know when I told our team at AIDS United 6 months ago that we should convene this special edition of AIDSWatch is that our world would change, that our advocacy would need to change, and that AIDS United would be needed to help our community through this year of momentous changes, especially as we face the most important presidential election in most of our lifetimes. And we did know that our community would be resilient because we have always been resilient. So this AIDSWatch is about being on our road together, our road of resilience. Resilience in these unprecedented months and forging our road of resilience forward to face the changes and challenges of today and in all the months ahead. So thank you. Thank you for being on the road to resilience with us. And thank you to our partners, the Treatment Access Expansion Project, and the U.S. People Living with HIV Caucus for joining with us in mounting this special edition of AIDSWatch 2020. And thank you to our sponsors, OraSure Technologies, Avita Pharmacies, and Merck. We could not do this without your support. And thank you for your advocacy. Together, we are powerfully resilient, and we will continue working to end this epidemic, even in the midst of our call for racial justice and while fighting COVID-19. And we will be resilient no matter who wins the election.
Good afternoon. My name is Vanita Ray, and on behalf of the U.S. People Living with HIV Caucus, I would like to extend a warm welcome to over 900 AIDSWatch participants that have come together virtually to build power, even during a pandemic. The world has changed drastically since we were together in March, that it feels like a lifetime ago. We are in the midst of a pandemic, racial uprisings, a recession, and one of the most important elections of my lifetime. The world has repeatedly witnessed anti-Black racist violence, attacks on health care, especially for people living with HIV, and challenges to the safety net that some of our members depend upon. The caucus stands in solidarity with you all in the fight for racial justice, human rights, bodily autonomy, an end to anti-Black state-sanctioned violence, and health disparities experienced by our Black, Brown, and Indigenous communities. AIDSWatch continues to be one of the most important convenings for the HIV community to ensure that the needs of people living with HIV are met. So again, I hope you learn a lot ask the hard questions, and make sure that the needs of our Black, brown, cis, trans, gender nonconforming, male, female, our sex workers, and people who use drugs are respected, acknowledged, and treated with human dignity. Thank you.
Good afternoon, everyone. I'm Robert Greenwald, the Director of the Center for Health Law and Policy Innovation's Treatment Access Expansion Project, one of the lead convening organizations of AIDSWatch. Welcome to Road to Resiliency, a special session of AIDSWatch for us to come together and discuss how we sustain our advocacy around ending the HIV epidemic in the United States. We are in the midst of a global pandemic, a national reckoning on systemic racism, and a looming federal election. The future direction of the United States is uncertain. Focusing in on healthcare, it is more important than ever to protect the gains achieved through the Affordable Care Act. We must also promote additional reforms that eliminate health inequities and secure HIV and other care and treatment needs for all. We have already made progress. Since the ACA was enacted, the number of uninsured people has dropped by over 20 million, an over 40% decrease. We have also seen significant progress in lowering the healthcare coverage gap for Black and Latinx people. Most important, we've gone from a 25% HIV viral suppression rate in 2010 to a 68% rate in 2018. The path to ending the HIV epidemic is clearer than ever. Still, we know that we're far from where we need to be. Black and brown people continue to have increased barriers to healthcare and worse health outcomes than white people. And since Trump took office, we've seen regular attacks on our healthcare rights, from work requirements in Medicaid to public charge rules that threaten immigrants' access to healthcare, to the elimination of non-discrimination protections for transgender and gender non-binary people. Even in the midst of the worst public health crisis in over a century, Trump and officials in 18 states are asking the Supreme Court to invalidate the Affordable Care Act. We remain one of the only major industrialized democracies without a national healthcare system, and people of color bear the brunt of these burdens, with COVID-19 shining a harsh light on the impact of structural and institutional racism in our country. Black and brown people are 3 times more likely to contract the virus and twice as likely to die from it. The road to resiliency is about working together to making sure our advocacy remains strong in addressing the HIV epidemic. To accomplish this, we must eliminate the shortcomings in our healthcare system, particularly those that perpetuate barriers to care and health disparities. Today, we need to talk about the COVID response that follows science over politics and that builds off of lessons learned as to what a sound and more equitable public health response looks like. We need to mobilize in support of the Affordable Care Act, as it is never the right time to let 20 million people become uninsured, let alone in the midst of a pandemic. And finally, we need to talk about voting in the upcoming elections, including what it will take to win the trifecta, the presidency, the House, and the Senate. No matter what, there is no compromising in doing what it will take to end HIV. I look forward to working together on the road to resiliency, doing all we can to ensure that healthcare and other basic human rights are in fact rights and not privileges only for some people in this country. Welcome to Road to Resiliency. Thank you.
Hello, I'm Congresswoman Barbara Lee, and I proudly represent California's beautiful 13th Congressional District, which includes Berkeley and Oakland, California. Thank you to AIDS United for inviting me to speak with you today. I would like to welcome this year's conference participants and thank you for your critical work towards ending the HIV epidemic. When I first came to Congress in 1998, I came committed to ensuring the United States was a leader in the fight against the HIV/AIDS epidemic. I worked with the Congressional Black Caucus and President George W. Bush in 2003 to create PEPFAR to address the global HIV/AIDS epidemic. This program has saved over 18 million lives internationally. One of my proudest moments was founding the bipartisan HIV/AIDS caucus in the United States Congress in 2011 with former Representative Jim McDermott and Representative Trent Franks. But there is still work ahead to end the domestic HIV/AIDS epidemic, especially for racial and ethnic minorities who disproportionately are affected by this crisis. Funding for research is in jeopardy under the Trump administration, which is trying to eliminate the $54 million budget for the Secretary of Health and Human Services Minority AIDS Initiative. As a member of the House Appropriations Committee, I will continue to work with my colleagues in Congress to push funding for HIV programs and research and do all I can to reject this administration's attacks. We need to ensure that we continue to fund critical programs such as the Ryan White program. This is why in my position on the House Appropriations Committee, I was able to help secure $2.4 billion for the Ryan White program, which was an increase of $25 million this year. That's also why our work is more important than ever. We must continue fighting for an end to the HIV epidemic in our country and ensure that these critical programs and research initiatives are protected. Thank you again for your advocacy and commitment.
I'm Jennifer Gonzalez, and I represent the people of Puerto Rico in Congress. I want to say thank you to AIDS United, to the Treatment Access Expansion Project, and the U.S. People Living with HIV Caucus for inviting me today. Last December, I was proud to join Congresswoman Barbara Lee as the Republican co-chair of the Congressional HIV/AIDS Caucus. It was founded in 2011, but I think now we need to support President Trump new ending the HIV epidemic plan, which he announced during his 2019 State of the Union address. This is a 10-year initiative that began in fiscal year 2020 with a goal of reduce the number of new HIV infections in the United States by 75% within 5 years, and then, but at least 90% within 10 years. For an estimated of 250,000 total HIV infections averted. We must ensure that this initiative is funded at no less than $760 million requested, while at the same time, we should be securing continued support and increased funding to critical programs such as the Ryan White and the Housing Opportunities for Persons with AIDS program. Also, I think Congress should pass the Repeal HIV Discrimination Act, or H.R. 6054, that Congresswoman Lee and I introduced in March. This bill will modernize laws and policies to eliminate discrimination against those living with HIV and AIDS. Federal and state laws, policies, and regulations should not place a unique or additional burden on individuals just because of their HIV status. And this bill offers a step-by-step plan to work with states to modernize all their laws. We have made incredible progress in our fight for an AIDS-free generation, but AIDS remains one of the greatest humanitarian crises of our time. I think Congress must continue to work together across the aisle with the administration and organizations like yours to support programs we know are working. I think we have an exceptional opportunity to end the HIV epidemic in America in the 2025, and the time to do it is now.
Hello, everyone. My name is Tyler Termier, and I use he, him, his pronouns. Today, I'm serving as the moderator for the opening panel at AIDSWatch Road to Resiliency, and am joined by a rather brilliant group of my colleagues from around the country to discuss how we sustain our advocacy around ending the HIV epidemic in the United States amid COVID-19 and the crucial focus on racial justice. During this time together, we will hear from Greg Millett, Vice President and Director, Public Policy at AMFAR, John Carlo, the CEO of Prism Health North Texas, Monique Tula, Executive Director of the Harm Reduction Coalition. In my own personal life, I serve as the CEO of Cascade AIDS Project in Oregon and Southwest Washington State. I also proudly serve as the co-chair for the AIDS United Public Policy Council. Before I turn it over to our first presenter, I'll use my moderator's privilege today to frame our discussion. Since we last virtually met for AIDSWatch earlier this year, the COVID-19 pandemic has continued to unfold rapidly and has challenged all of us in different ways, both in our individual lives and in the ways we function within our organizations. The last several months have been a test of our resilience. It has pushed us all to be adaptable, to innovate and be nimble in the ways we operate and deliver our programs and services. It has made us ask ourselves not only who we choose to be as organizations during public health crises, but also who we want to be on the other side of this pandemic. It has made us a stronger people and highlighted how essential our work is in our pathway to ending the epidemic. However, the harsh reality is that often what is essential is invisible to the eye. The impact of COVID-19 has only further uncovered and made more publicly visible the many existing crises in our communities. Conditions of poverty, addiction, mental health, and economic injustice, gender bias, gender-based violence, white supremacy, and racial trauma create settings in which inequities continue to thrive. They are among the social determinants that fuel epidemics across our nation and every day in the communities we live and serve. It's yet another defining moment in our existence as a movement, and we have to decide who we want to be on the other side. Now, our community is not new to this moment. We have been a part of it time and time again during the civil rights movement, together at Stonewall, in the suffrage movement, and during the height of the AIDS epidemic. Through it all, we have remained strong, steadfast, and resilient. As conversations commence about how our communities might begin to further relax physical distancing and relaunch our shuttered economy in the future, I'm not interested in a dialogue about when we return to normal. We must be intent on creating a pathway forward towards a more equitable nation and response to ending these epidemics. On a personal note, as a Black, openly gay man living with HIV for nearly 17 years, I have a very real concern that the decisions being made today will have a drastic impact on tomorrow. And that's why I'm doubling down on my commitment to leading with race within my own organization and community, to leading through these difficult but crucial conversations and getting out the vote so we can see a change in November and solidify our blueprint for what we know is possible, ending the HIV epidemic. With that, I'll turn it over to my friend and colleague, John Carlo, the CEO of Prism Health North Texas. Oh, I might be wrong. Greg Millett, I think you're first.
Hello, everybody. I hope that everybody is safe and well. I know it's been a difficult time over the past 6 months, but there is an awful lot that we really need to discuss regarding COVID-19, and I'm happy to join you today as part of AIDSWatch to talk about what we've learned over the past 6 months. Next slide. Next slide, please. So one of the things that we've learned is, unfortunately, we have colleagues who are gone too soon because of the COVID-19 pandemic. Many of you have known Barbara Joseph, Dolores Dockery, Ed Shaw, all giants in our community, who unfortunately passed away during the COVID crisis. And as many had already revealed previously, COVID-19 is taking aim at many communities of color, and particularly seniors in communities of color, whether or not they are HIV positive. These are data that are from Kaiser Health News, where you could see very high rates of COVID-19 among seniors between the ages of 65 as well as 85 and older. And you see the particularly high rates for African Americans, but you also see very high rates as well for Latino communities. Next slide. And speaking of Latino communities, my colleagues and I worked on several studies over the past 6 months to really expose the degree to which COVID-19 is impacting communities of color. There's one study that we just published last month with Carlos Rodriguez Diaz at George Washington University. And one of the things that we found is that Latino communities in the US, the biggest predictor, one of the biggest predictors was being monolithic Spanish speaking. And it's not just our study that found this. Next slide. There was a recent study that was just published in JAMA that found exactly the same thing, that people who are non-English speakers have higher rates of COVID-19 diagnoses as compared to people who speak many different other types of languages. And you could see on the arrow on the bottom there that monolingual Spanish speakers had a very high rate of positive cases. It was 25% positive case rate compared to English speakers that was only 4%. Next slide. And it's not just the COVID-19 and race and ethnicity. We know another issue is mental health as well as depression and stigma. This is something that we've all known very well from HIV. And unfortunately, we're seeing the same thing with COVID-19 as well. During the COVID-19 era, we have seen mild depression, moderately severe depression, and severe depression skyrocket from before the epidemic. We're also seeing higher rates of stigma that's being leveled at many of our communities, with Black, Latino, and particularly Asian communities who are experiencing higher levels of stigma in the COVID-19 crisis. And we all know that stigma is associated with not taking your pills, with lower viral suppression if you're HIV positive. Next slide. And unfortunately, COVID-19 is also exposing something else that's been taking place. There have been many studies that have been coming out, many reports in the media of greater rates of domestic violence during lockdown for COVID-19. Next. And unfortunately, this is also associated with an increase in domestic violence in specific areas in the US. So for instance, over 25% in Jefferson County, Alabama, Portland, Oregon, over 20%, San Antonio, Texas, an increase of over 15%, New York City, an increase of 10%. And why this is important is because we know that domestic violence is associated with lower antiretroviral therapy access, lower use, lower adherence for women living with HIV, as well as greater rates of viral suppression or lower rates of viral suppression. Next slide. And unfortunately, it keeps going. We're also seeing higher rates of substance use hospitalizations and deaths during the COVID-19 era. So we already saw greater rates of hospitalizations for African-American substance users as compared to white users. But now after COVID-19, it's the two middle bars that you see there, that anybody who reported any substance use over the past 6 months during the COVID-19 era, it's much higher for African-Americans, and same thing for African-American recent substance users who have been hospitalized. Next slide. Next. And the same thing, unfortunately, we're seeing with death rates. Death rates are also far higher for substance users who are African-Americans compared with whites. Next. And what makes all this worse is the fact that we're not only dealing with the disease, we're dealing with this syndemic. So we have this economic recession that's brought on by COVID-19 that's primarily impacting communities of color. So you're seeing Latino, Black, Native Americans, all reporting far higher rates of serious financial problems during the pandemic. And unfortunately, right now, we're also in the midst of an eviction crisis that's taking place that's going to be affecting many of our communities, particularly in communities of color. And that, of course, has perilous consequences. Next slide. And one of those consequences, of course, is the fact that we have already seen in various studies that when you have higher rates of homelessness, you also have lower rates of viral suppression and higher rates of mean viral load. That's exactly what they found in a study to the left. As the bars go from light blue all the way to dark blue, and dark blue is more homeless, you see higher rates of mean viral load and lower rates of viral suppression. And to the right of that is a separate study that was also done in San Francisco, where they found that people, if they were diagnosed with HIV and they were homeless as they were diagnosed, they were 27 times more likely to die from HIV earlier than people who are diagnosed with HIV and not homeless. Next slide. There are some good things that we are seeing, though, during the whole COVID-19 era, and one of them is Medicaid expansion. There have been several states that have not expanded Medicaid. Several of those states are also part of the EHE, ending the HIV epidemic initiative that President Trump is doing. Next. But because of COVID-19, we're seeing more COVID-19 deaths that are taking place in red states in the United States. And we're seeing this progression now through September, where red states have eclipsed blue states in terms of COVID-19 deaths. And that's prompting more red states to actually reconsider Medicaid expansion, with Oklahoma doing that, Missouri doing that, and now Mississippi and others are thinking about following suit. Next slide. The other things that we're seeing that are perhaps silver linings with COVID-19 and perhaps ways that we might want to consider changing doing business is we're seeing a growth in telehealth and more people who are interested in telehealth. And the fact that it's been much easier for some members of our community to be able to keep their appointments via telehealth, particularly if they didn't have access to transportation. And we're also seeing that for those members of our community who are dealing with opioid substance use disorder, that access to opioid substance use therapies such as buprenorphine and even methadone is much easier in the COVID-19 era, where people are actually able to take their medications home. Why this is important? It's important because we know that if you are an opioid, or if you're an opioid substitution therapy, and if you're HIV positive, you're more likely to adhere to your medications. You're more likely to be virally suppressed if you have access to your opioid medications. So the fact that we have people taking them home, whereas before they weren't able to do so, is something that we need to consider and continue after COVID-19. Next slide. However, we still have a lot of looming questions and issues only 6 months in. For instance, what is the impact of COVID-19 on transgender populations? We still do not have enough data. There have not been enough studies to try and figure out exactly what's taking place among our brothers and sisters who are living with HIV or at risk for HIV who are transgender. We also don't know how much off target COVID-19 is taking us. How much is this going to increase some of the disparities that we've already seen that have manifested in HIV over the many years? We also don't know how much funding will be required for COVID-19 and how will that affect the EHE budget for ending the HIV/AIDS epidemic. We already know that many AIDS services organizations are having a hard time to hold on and trying to survive during this economic crisis. And to just put a final lid on that, take a look at the right-hand side where you see this tweet from Dr. Tom Frieden, who used to work at CDC, who's the head of CDC. And you can see that for SARS, H1N1, Ebola, et cetera, that they all cost the American economy over 10 years about $55 billion or $40 billion. COVID-19, unfortunately, is costing us nearly $9 trillion. And this is something that could have easily been prevented. But unfortunately, that is going to affect our budget for HIV. That is going to affect our budget for EHE. And then the last point that I have on this slide is something that I think we're all thinking about. Can we actually trust an administration that politicizes science with ending the HIV/AIDS epidemic? Next slide. And part of the reason that I say this is because there was a really interesting quote today from Dr. Tom Frieden, who used to be the head of CDC, where he said that you have standard principles of risk communication to the American public. Be first, be right, be credible, and be empathetic. If anyone tried to violate these principles more than the Trump administration has, I don't think that they could. And this is part of a pledge that I have taken when I was a scientist at CDC and many of my colleagues at CDC have taken. And the pledge is you be diligent towards the funds that are entrusted to your agency. You provide an environment for intellectual and personal growth and integrity. You base all public health decisions on the highest quality scientific data that is derived openly, objectively. You place the benefits to society above the benefits to your own institution. And you treat all persons with dignity, honesty, and respect. Next. So how do those principles compare to what we're seeing with the Trump administration as they're interfering with CDC's data, the release of data for school children, the release of data on the number of people who are asymptomatic for COVID-19, and all sorts of other scientific data? It's incredibly problematic. And how can we trust an administration like this for the stewardship of EHE? Next slide. So in summary, HIV diagnoses are likely going to increase during the COVID-19 era and past the COVID-19 era. We're going to see racial disparities that are going to increase. We're also going to witness an increase in diagnoses among women, substance users, and gay men. And it's problematic because we've seen trends where among women and substance users that diagnoses have been decreasing, and we think that those trends are probably going to be reversed. We don't have enough data on transgender populations. We don't know how COVID-19 is affecting them. We also know that stigma and depression from COVID-19 in isolation can impact people living with HIV or at risk for HIV. We know that most of us who are living with HIV are over the age of 50, so we're at risk for COVID-19 and will continue to be at risk until we have a vaccine that's available for most of the public. We also know that there's economic fallout and homelessness that's going to impact many people living with HIV. Next. And you could just keep hitting all of them. And we also need proposed funding for EHE that is really at scale for the crisis. Right now, the proposed funding for EHE is not at scale for the crisis. There are also good aspects of COVID-19 that we need to take a look at. We need to make sure that we have take-home opioid substitution therapy, telehealth, as well as greater Medicaid expansion. We need to fight for ACA and fight for Medicaid expansion. COVID-19 has also exposed something incredibly important. It's exposed the importance of social determinants. And what's clear when you take a look at the Ending the HIV Epidemic plan that we currently have is it does not deal with the social determinants of health. And it makes me wonder again, how can we have EHE move forward if it cannot deal with the basic things that many of us are grappling with during the COVID-19 crisis? And the last, an administration that's willing to lie and politicize science jeopardizes all of our health. And the two other points that I want to make is that this is a time now when we need to support our agency partners. There are many people that we know and love who work at many of these agencies. We've known them for many years. We know that they're trying their best to help the HIV community, and they're dealing with a very difficult administration right now. And we need to try and support them as much as we possibly can. And most importantly, as we talk about resiliency, we need to do more to support one another now more than ever to make sure that we can all make it through this crisis unscathed and to make sure that we can actually see the end of HIV as well as the end of COVID-19. Next slide. Thank you for your thoughts. Here's my email if you would like a copy of the presentation. And on the right-hand side is a link to a data dashboard that we have that tracks racial inequities and COVID-19. Thank you.
Thank you so much, Greg. We are truly all in this together, and it's going to take all of us to come out a stronger, more resilient community on the other end. Just a few quick reminders for our presenters today. We do have ASL interpreters, so if you can control your pace. I was speaking a little too fast earlier, so I hope you all can set a better example. And if folks, as folks are on the call, if you have questions, feel free to use the answer box at the bottom of your screen. I'm going to turn it over to you, Giancarlo.
Well, thank you, Tyler, and thank you to AIDS United for the opportunity to be here and join you on this opening panel discussion with esteemed colleagues. And I have to say that it is a tough act to follow Greg and his great presentation. I will do my very best to bring up points along the way, just as he did, questions that I think we have in the relationship of COVID-19 with HIV and AIDS in this country. So if you go to the next slide, please, and the next slide. So Greg did a great job of pulling out some of the very specific points. And so I think one of our goals for this conference is to really talk about this intersectionality of HIV and COVID-19. And, you know, to start from the very beginning, I think that in the studies that we've seen so far, the HIV virus itself and the infection that it causes doesn't look like it has a tremendous effect in causing more coronavirus infection severity. We've seen several studies across the world that have kind of demonstrated this to this point. Of course, there's more data that is much needed on this. There was, of course, the question that antiretroviral medications, the HIV treatment itself, actually could have some protective effect or treatment effect with COVID-19. And at this point, we don't see that as something that is of a benefit, still to be determined. But at this point, the antiretroviral medications don't look like that they will have that effect. But with all that being said, as we've talked about, there is this interrelationship between HIV and coronavirus COVID-19, and it's really looking at it from the syndemic model that we talk about. And it's really looking at it from the perspective of HIV, people living with HIV are more likely to have hypertension, high blood pressure, diabetes, tobacco use, older age, and things like that. And that's what leads us to look at the risk of COVID-19 in the HIV and AIDS community. And so, you know, when we talk about the syndemic model, we often talk about it as a conversation saying, you know, in this case, 1 + 1 probably equals way more than 2. And you really look at these co-founding factors as they affect the communities and see the disproportionality of those burden of disease. And so I think that this is another good example, unfortunately, of how two pandemics have come together to disproportionately impact communities in this country, communities of color in this country, and our lower socioeconomic groups. Next slide, please. Well, you know, and I'm putting some different pieces together because I have a lot of questions, as I'm sure you do. What is this all going to mean? You know, in this dramatic first 6 months as what's happened to us as a community, how has this affected our interactions with one another? And what is going to happen as a result of these experiences that we've had? We've never seen anything like this in terms of a shelter-in-place, stay-at-home order. So the question is, what is going on in terms of our community? And, you know, we ask this question very freely among ourselves. You know, what is happening? Are we having more sex? Are we having less sex? Are we having more casual sex? These are important questions for all of us to consider that have worked in the HIV and AIDS community. And I think this is a rather remarkable thing that even before the COVID-19 situation, our process for coupling changed very dramatically overnight. And I was just astounded by this slide. You know, keep in mind, after World War II, we virtually used friends or friends of friends for the purposes of coupling up until very, very recently. And then online dating and online meeting has really driven well above, to the point that 60%, 70% of heterosexual couples are now meeting online. This is this framework or the background that we now have, and let's talk about what that means in terms of coronavirus and stay at home. As you can see here, the CEO of Match.com has seen this already, and we have seen a dramatic increase of use of these apps and increasing video dating, virtual dating, using social media and these types of things. So the question becomes, what does this all mean in terms of HIV risk? Is this perhaps a way to lessen that risk or to increase the risk? And I think the question is still there, something we do not yet know. Next slide, please. Well, what about the communities of men who have sex with men? What do we know about how the effect of COVID-19 has impacted the MSM in the United States? There are 2 surveys that are out just recently published in AIDS and Behavior. Keep in mind, these are relatively large surveys, but they did not oversample minority groups. This was a online convenience sample of about 500 to 1,000 participants, men aged 15 to 45. But in this segment, we can see that there was a very high rate of job loss reported, very high in the ages of 15 to 24. This would be higher than the non-MSM population. The use of alcohol and substance use is showing to be increased, particularly in the MSM community. Many felt the loss of connection to friends and family. They did show a mean increase of 2.3 sex partners comparing to pre-COVID in both of these surveys. The use of online dating is mixed, but reported to be higher during this time in younger men. And the other thing that's very important for all of us to know is that there is reports of difficulty of getting access to services, both for HIV treatment, STI testing, and PrEP. Next slide, please. So the service disruption, I think we all are familiar with this, those that are on the front lines. There is multiple points along the way where we, I think, have to be very concerned is the impact of COVID-19 on the vital services that we have, both in HIV treatment and prevention. The first is a concern that I think we all should share is the impact of drug shortages as a result of COVID-19. Keep in mind that we estimate up to 90% of all of our pharmaceutical drugs have some interdependency of international supply, and disruption of those supply chains could very, very easily result in shortages. And additionally, the FDA does not have enough ability to ask where those vulnerabilities are in the supply chain. So our manufacturers do not have to supply anything that is related to in terms of pending drug shortages or perhaps risks around that for the supply chain. So there is a real lack of transparency in our drug manufacturing process that I think we should all be concerned about. The second one is the Dear Colleague letter that came from the CDC saying that there's a shortage of the STI kits and treatment testing kits that are available. And they're asking us to consider not testing for asymptomatic individuals in certain circumstances, and to also defer testing if it gets worse for even populations that really need these tests, for example, people that are on PrEP. And so there's a lot of concerns, and keep in mind that many of these test kits do have similar materials that are used for COVID-19 testing. So these types of shortages are obviously natural, but certainly concerning, I think, for all of us that are working to continue to get good STI treatment. And I'll show you some of our experiences in Dallas as a result of some of that. This is in addition to our clinics, of course, having to close our doors due to the shelter-in-place orders, being able to manage effectively patients for STI screening. This requires, of course, the amount of PPE that's required, personal protective equipment, which also became in short supply. And finally, what was a report from NASTED, the National Association of State and Territorial Health Directors, looked at there's been a huge amount of redeployment of public health staff who are normally on the front lines of HIV surveillance and epidemiology and STI treatment. They are being redeployed as to other areas around the COVID-19 response. So all this comes together to a massive amount of service disruption that I think is very, very consequential. Next slide, please. This shows you that this is some examples. This is a report from Fenway Health in Boston that was presented at the International AIDS Conference this year, showing the degree of different testing decrease. HIV and chlamydia testings were down by 85% on the initial side. This map on your right shows in South Carolina a very interesting intersectionality between the Ryan White clinics that either had a service disruption or closure, really mapped highly to where the coronavirus cases were occurring. So the darker areas are showing the higher coronavirus case rates, and you can see that the closure of the clinics are mapping right on top of that. The concern that brings up is, of course, the intersectionality of COVID-19 and HIV, the high likelihood that these service disruptions are most likely impacting the most who need the treatment, particularly for the Ryan White funded services. Next slide, please. So a little bit about our experience. As I mentioned, we want to know what's out there, what's going on in our community, and I can tell you from our experience, we've had a dramatic increase of sexually transmitted infection visits, requests for treatment, walk-ins to our clinic sites. If you can see the bars in front on the right side show that both the 3 months pre and the 3 months during early on with COVID-19, almost double the number of patients have come in for STI treatment. And we're seeing about a 23% positivity rate on our STI screening. And most of these are asymptomatic. So this goes back to the shortages that are recommending only for symptomatic treatment or reserving those. We would be missing a lot. in terms of STI treatment if we are only doing a symptomatic treatment and testing. So now I do preface this, and I think that this is a conversation about not just what's going on in terms of the STI epidemic. This is more a fact of what's happened with our partner service organizations that have had altered hours or closed or disrupted services. So we think that this is really more the result of people coming in because they had not been able to find the services available elsewhere. Next slide, please. So this is a group that needs to be aware, I think, of the big threats in terms of what's happening in HIV treatment. And I think the big thing that we're seeing right now is several things. Number one, I think for those on PrEP or thinking about PrEP, we have seen a tremendous threat around having choice of medications for that PrEP service. And I think that there's some real concern that health plans could exclude the Descovy medication in result of the generic coming on board. And where that really hurts and affects us is there are definitely patients that I think will benefit by having the option for Descovy, particularly if there's evidence of kidney disease or bone disease. And so we do think that there are restrictions of formulary that are coming. I think the end result of that is actually patients are going to simply not go on PrEP because of the fears around those potential kidney and bone disease. So I think we are potentially here seeing some risks that I think shouldn't be there. So this is a place where I think we need to be on the front lines with this conversation and making sure that these health plan decisions do not interfere with medical judgment and they do allow patient choice. Secondly, the 340B program is the lifeline for HIV treatment in this country. And we've seen a number of moves, overt moves during this coronavirus crisis that the drug manufacturers have taken on that could have profound impact on our ability to provide effective HIV treatment and comprehensive HIV treatment. The simple move of not allowing us to purchase the drugs through a contract pharmacy really is going to actually disproportionately impact our uninsured patients, because right now we purchase uninsured medications and deliver those medications. We use grant funds to support that service. Not being able to purchase those drugs at 340B price essentially doubles our cost and basically halves the available medications that we can provide for patients. Now, thankfully, these are not HIV medications, but these are medications that are absolutely essential nonetheless, like insulin, antidepressant medications, you name it. So I think we're under real threat from the drug manufacturers. I think we all have to do our part to understand that these are real threats that we are all going to be challenged with in order to make effective HIV treatment available for everyone in this country. Next slide, please. So I had one more, but my last slide was an acknowledgement and thank you. And again, thank you for the opportunity to be here. I want to recognize my staff and again, thank you. And I will pass back to Tyler.
Thanks so much, John, for highlighting the importance of intersectionality between these co-occurring pandemics. I am thrilled to turn it over to my friend and colleague, Monique Tula, to talk to us for the next few minutes. Monique?
Hello, just want to make sure you can see me. You can hear me? Great, thanks, Tyler. So hello to everyone, greetings from sunny and smoky California. I want to thank everyone at AIDS United, the caucus, and Treatment Access Expansion Project for the invitation to talk just a little bit about the harm reduction response to COVID-19. Next slide, please. So it's First Nations protocol to acknowledge the traditional territories that we visit, and being in a virtual setting doesn't preclude us from honoring the First Nations tradition of acknowledging the land that we're gathered on. So I'd like you to join me in paying our respect to all of the Indigenous folks across the country and around the globe who are the original custodians of the land under our feet. And we've heard a lot of heavy information so far, and if you'll indulge me just a moment more, I'd like to take just 30 seconds to ground ourselves and bring our awareness into this moment. So if everyone if you can just take a a single deep breath. Hold it for 3 seconds. Exhale slowly. Notice the sensation of the air leaving your lungs. Now imagine if we were all together in the same place, the same physical location, doing that in the same moment. Feel that connection that we have with one another across time and across space. We're all here together. Thank you. The National Harm Reduction Coalition creates spaces for dialogue and action that help heal the harms of racialized drug policies. And a number of years ago, about 2 years ago, we made the bold decision to create that North Star statement because we understand that people who use drugs are not single issue case studies. We are whole people with intersecting identities and beliefs, complex histories and behavior. Many people who use drugs do so to mitigate the impact of personal and intergenerational trauma. Many people who use drugs do so to cope with collective trauma caused by systemic violence like genocide and slavery and the war on drugs. Next slide, please. So I can't talk about the response, the harm reduction response to COVID without first naming white supremacy, which is what sustains the conditions under which Black, brown, and poor people struggle to survive, much less thrive. Those of us who are demanding racial and economic justice, we have a long road ahead of us, and it's taken centuries to get to this point. But in stark contrast to the policymakers who have created and perpetuated the war on drugs, the harm reduction community believes that there's another way. So 2020 is teaching us an awful lot about who we are and why we're here. We're beginning to understand what intergenerational and collective trauma is. We're beginning to understand why people who use drugs were often trying to mitigate the impact of untreated mental health, social isolation, homelessness, and that cycle of generational poverty. I believe that we are all suffering from collective trauma, some of us more obviously than others. A collective trauma is something that happens over generations and across communities. It began with our ancestors and continues often uninterrupted to the present day. War and genocide, slavery, mass shootings, severe poverty, famine, and natural disasters are all sources of collective trauma, while rage, depression, denial, and survival guilt are symptoms of collective trauma. Next slide, please. Now, traumatic experiences can lead to psychological, physiological, societal consequences as our reality is turned upside down. We're seeing it now. And although trauma is dealt with collectively, individual responses can often look very different. And that helps to explain some of the confusion about what collective trauma actually looks like. So collective trauma often manifests as illness. For those of us who are working in HIV over the past 3 decades, we know that there's been significant collective impact on our communities, and there are similar impacts for the opioid crisis and of course, COVID-19. Next slide, please. So we typically use trauma to describe the impact of an incident or a series of incidents on a single person or small groups of people. But collective trauma refers to the impact of the traumatic experience on entire groups or of people, entire communities and society itself. Collective trauma can alter policies and governmental processes. It can alter the way society functions and change societal norms. So the 9/11 terrorist attacks is an example where the US changed transportation and travel policies to supposedly enhance security. And 9/11 happened nearly 2 decades ago, but its impact completely transformed the way we move through the world. and many are predicting that COVID-19 will permanently transform the world as well. We're entering a new normal. Next slide. So I want to take a closer look at the way public health policy alone isn't sufficient enough to mitigate the massive impact of the trauma caused by COVID and HIV or the overdose crisis. So the San Francisco Department of Public Health recently released the final overdose death data for 2019. They experienced a staggering 70% increase in overdose deaths last year. That's 441 people who died from an overdose. That's more than one person a day for the entire year. The report also showed that the majority of opioid, meth, and cocaine overdoses occurred among Black people, men, and people over 50, while fentanyl-related deaths primarily occurred among younger people. Next slide. So the numbers have almost doubled from 2019, and given what we already know about this year, in 2020, we'll see a doubling or more of overdose fatalities, made even worse as COVID disrupts social services, exacerbates drug use, and pushes more and more people toward poverty, homelessness, and isolation. The San Francisco data from 2019 confirms that what many of us already knew about overdose. The factors that make people vulnerable are either compounded by or caused by poverty and state violence. And they're the same factors that drive HIV prevalence. Many of the risk reduction strategies for COVID are in direct conflict with harm reduction protocols for avoiding overdose. So we advise people to stay home and isolate for COVID. But for people who use opioids, that could mean the difference between life and death if no one is present to reverse an overdose or call an ambulance. And despite the hundreds of thousands of dollars invested in the country's largest naloxone distribution program, even a city like San Francisco, resource-rich and often lauded as an innovator of public health practice, doesn't have adequate policies and services to handle the surge of fentanyl on the city streets or COVID-19. Next slide, please. So as part of the National Harm Reduction Coalition's response to COVID, I convened a bi-weekly mutual aid and support group for executive directors of harm reduction programs around the country. We're still meeting, and during a recent meeting, one of our colleagues said something that I thought was particularly profound. She said, harm reduction programs can help keep people alive just long enough for them to get COVID. And that's a pretty extreme comment, but for many, it's not untrue. Next slide, please. So nearly dwarfed by the COVID-19 pandemic, the overdose epidemic is still one of the defining crises of our time. Greg spoke about it earlier. And of course, COVID is complicating our response to the opioid crisis. So the provisional mortality data, this data that I'm showing you here, it was collected by the New York Times, and it shows rising drug-related deaths well into 2020. Isolation has always played a role in drug overdose, and as the weeks of COVID-19 isolation and social distancing have gone on, we're seeing more and more opioid-related overdoses. So harm reductionists try to discourage people from using alone because, as I said earlier, if no one is around, the likelihood of a reversal is pretty minimal. But COVID has forced the curtailing of in-person treatment, group counseling sessions. So there's far less emotional support, which is vital to successful treatment protocols for substance use disorders. In response to COVID, medication-first approaches to treatment like MOUD, some of them have shifted to online virtual settings. And there's also some group counseling sessions that are available online. However, those are limited to people who have access to computers and the internet, of course. We're also hearing anecdotal evidence that the nation's closed borders are impacting people who use drugs because illicit drug supply is less predictable, right? So the constant changes in potency makes it harder for people to accurately judge the strength of the drugs that they're using. But even with COVID-induced loosening of MOUD prescribing rules, there are still far too many states that still don't have policies that support life-saving harm reduction strategies like syringe service programs and naloxone distribution, or even testing the drug supply for fentanyl. In fact, last year I gave a talk when we were still flying around the country. I was in Pennsylvania and I gave a talk and learned that it's still a felony charge to carry a syringe, and even more confounding, it's a felony charge to carry fentanyl test strips. I mean, how many more people have to die preventable deaths before we overturn these arcane Victorian-based values that and policies that are draconian and cause so much death and destruction? We should have an emergency response to COVID that's the size and scale of the crisis that we're facing. And looking back to San Francisco, after realizing the astronomical increase in drug overdoses during the first 6 months of 2020, there were some city councilors who actually introduced legislation that would force the medical examiner to report suspected overdoses 3 times a year instead of twice. And that doesn't typically happen because of cumbersome reporting like autopsy, toxicology, death scene investigation, medical records. So it makes a lot of sense to look at incidents more frequently, of course, but the people behind those numbers, they're already dead. And like COVID, the unabated rise of the opioid crisis highlight root causes that have been killing people in our community for decades. We can't end overdose until we end poverty and homelessness, incarceration, and state violence against Black and Brown people. We cannot end the overdose crisis with naloxone alone. The fight is bigger, and not a single one of us can fight it alone. Next slide, please. So in many regions across the US, drug-related stigma, lack of political will, zero funding, it's literally killing us. There was a 2018 CDC report that shows drug overdose and suicide are behind the largest decline in life expectancy since 1918, since World War I. We're losing an entire generation of Americans to addiction and overdose. We're familiar with the factors that drive what some are calling deaths of despair, like untreated mental health and trauma. Some argue that the most powerful driver of deaths of despair is economic insecurity that's been aggravated by the rise of the global market economy. For the first time in 100 years, the average life expectancy of white American men without a college education is declining. And the number one thing that's killing them is not car accidents, it's not heart disease, it's not diabetes. It's alcohol-induced liver failure and unintended injuries like overdose fatalities. So for white working class guys, things ain't looking so good. And nowhere is this more prevalent than in the impoverished Rust Belt of the US. And as an aside, which I thought was timely given the debates this evening, these trends are also pretty reliable predictors of who supports the kind of populist rhetoric that gave us the current administration, but that's a subject for another day. The holes in the safety net are larger than ever. We know this. And, you know, if one of the things that the overdose epidemic and COVID make visible, it's the flaws and the gaps in how we address substance use issues. We need to build a durable infrastructure that supports responsible systems and resilient communities. Interventions that work well, like using harm reduction strategies to identify, engage, and maintain relationships with people who use drugs, they haven't been brought to scale. And what operates at scale hasn't worked well, like punitive drug policies, interdiction, court-mandated treatment, and of course, incarceration. The war on drugs, the policies behind them, they're cause some of the most egregious harms committed against certain groups of people, and it's akin to slavery and genocide. And people who use drugs, especially Black and Brown people, poor people, who've been criminalized, stigmatized, brutalized, and murdered, all in the name of war on drugs. Harm reduction is more than good public health policy. By necessity, the harm reduction approach is an alternative to policing, and it's a political home for people who use drugs and their advocates. So if you want to learn a little bit more about the harm reduction response, including the National Harm Reduction Coalition, please visit our brand new website at www.harmreduction.org. Thanks for listening.
Thanks so much for your presentation, Monique. And I want to thank Greg and John for your presentations as well. We have reached the end of our first panel discussion. We know there was at least one question in the box, and so we'll make sure we get back to that individual. But this recording and the slides will be available to all those that are in attendance after the completion of AIDSWatch. So thank you all for your time, and I'm going to turn it over to Carl Baloney with AIDS United.
Good afternoon. I'm Carl Baloney Jr., Vice President for Policy and Advocacy at AIDS United, and I'm so thrilled to be joining our beautiful community of advocates from across the country in this special edition of AIDSWatch. 6 months since our regularly planned AIDSWatch, it's so important that we continue to convene to keep momentum on ending the HIV epidemic in the U.S. With that, thanks so much to Tyler, Greg, John, and Monique for talking with us about building resilience in our communities since the onset of COVID-19. We really appreciate you all being here and elevating your experiences and that of your colleagues across the field. Even though this event is about building resilience across our field, it wouldn't be AIDSWatch without talking about some policy. So I'd like to welcome representatives from my planning partners at the caucus and TAPE to discuss how some of our policy priorities have shifted since we last gathered in March. Welcome Ronald Johnson, Steering Committee Chair of the U.S. People Living with HIV Caucus. Ronald?
Thank you, Carl, and really thanks to all of the organizers and the planners, and to you, the participants in this AIDSWatch and road to resiliency, and recognizing that resiliency is a key feature of those of us living with HIV, and also our important and allies and fellow advocates. Since our virtual AIDSWatch in March, the policy priorities related to civil rights and human rights, which I would like to focus on in my brief remarks, have intensified. The explosive spread of the novel coronavirus epidemic and COVID-19 disease, the murders of and assaults on Black men and women by police forces, and the protests that followed, and the continuing impact of criminalization on people and communities that have been marginalized, have heightened the need for advocacy on racial justice, criminal justice reform, and health justice. The federal government ought to be the leader in protecting the civil rights and human rights and ensuring those rights of all people. Instead, we see, and many of us experience directly, the government failing to do its duty, especially for Black, Indigenous, and Latinx people, and LGBTQ people of all races and ethnicities. As advocates, we must urge the current Congress and administration, and the new Congress and the next administration, to fulfill their obligation to ensure and protect civil rights and human rights. And government's role doesn't stop at the federal level. We must also demand that state and local governments carry out their responsibilities to ensure and protect civil and human rights. That's why AIDSWatch at Home events are just as important as our national AIDSWatch. There are several policy priorities related to civil rights and human rights, but I'll highlight a few, and I hope that in our further discussion, we can bring out some more of the policy priorities related to civil and human rights. First, I would highlight the community-driven plan to end the HIV epidemic, which has been endorsed by over 250 national and state and local organizations, calls for significant intersectional criminal justice reforms. And those reforms include repealing laws that criminalize HIV and other infectious diseases, including COVID-19. And we need to recognize that COVID-19 has already been used, and almost from the beginning of the epidemic, been used to criminalize already over surveillance people and communities. We need to work on decriminalizing sex work, reducing mass incarceration, and removing the legal barriers to accessing public housing and other social benefits for people with past drug convictions. Another priority Congress must enact, and the president needs to sign, comprehensive immigration reform to protect due process of law for all immigrants and refugees detained by law enforcement and immigration authorities. Immigration reform has been long overdue, and we must continue to demand Congress and the president to enact and sign comprehensive comprehensive immigration reform. Related to immigration and the issues of immigrants here in the living in the United States, we need to demand that Congress repeal the administration's changes to the public change rule. After strong advocacy against that change, unfortunately, in the past week, the courts have allowed the administration to move forward with their their public charge rule, which is criminal in its effect. And we need Congress to act to change that rule and to reverse it. We also need Congress to really weigh in on what the administration is doing to dismantle Section 1557, which provides important prohibitions on discrimination under the Affordable Care Act. So these actions need to be strongly opposed, and we need Congress to work to reverse those decisions. We need, at all levels of government, we need to address the numerous ways communities of color, particularly Black communities, have been disproportionately incarcerated and policed by punitive drug policies. We need further protections for transgender people, and we need Congress to stop and oppose rules that have been enacted by this administration that put severe restraints on the rights of transgender individuals, including rights to housing and shelters, and to actions that have reversed the protections that transgender people realize under the Obama administration that have been reversed. We need Congress to step in and restore those rights of transgender individuals. We also need, looking at the broader LGBT community, we need the Senate to enact the Equality Act. The House has passed that legislation. That legislation is stalled in the Senate, and we need the Senate to move forward and pass the Equality Act to ensure the civil rights for all LGBTQ individuals. You know, above all, we need to address at all levels of government the issues related to racial justice and anti-Black discrimination and stigma. These issues have been neglected for far too long. The past several months and the unrest around that, again, following the murders and assaults on Black men and women have highlighted the need for racial justice to be front and center in our agenda. And certainly as we advocate through AIDSWatch and other forums, we must make addressing racial justice and dismantling all systems of structural racism and anti-Black stigma and discrimination need to be part of our agenda. I'm going to pause now and pass it over to my other colleagues, but I hope that we'll be able to engage in a conversation, a virtual conversation about the kinds of actions that need to be taken, not only to protect civil and human rights, but all the other issues of health justice that we'll be discussing on this panel. Thank you.
Ronald, thank you for that great overview on racial justice and equality. Now I'm going to talk to you all about federal appropriations. As they do every year, Congress is currently deciding the federal government's annual spending plan through the fiscal year 2021 appropriations bills. The bill that contains most of the funding for domestic HIV programs is a Labor, Health, and Human Services bill. While the House's passive version of this bill that supported most areas of HIV/AIDS related funding with increases from last year amounts, it is likely that some part of the fiscal year will be funded through a continuing resolution, wherein Congress decides to maintain the previous year's funding levels. When members of Congress do create legislation for the new fiscal year, they must ensure that the Labor, Health, and Human Services bill ensures necessary levels of funding for advancing and improving HIV/AIDS programs, plus an additional focus on minority populations, given the crucial issue of racial justice. Lawmakers must also not include any language restricting the use of funds for purchasing syringes or other vital harm reduction supplies that allow us to move closer to ending the domestic epidemic. Furthermore, we're going to talk about some issues around the U.S. Postal Services. Advance the Postal Service slides. Another crucial area of financial and regulatory support where Congress should focus is within the U.S. Postal Service. Postmaster General Louis DeJoy has implemented changes such as removing sorting machines and mailboxes. That jeopardizes both the upcoming elections, vote by mail procedure, and the value and convenience of getting prescriptions by mail. Mail order pharmacies allow people to receive medication in a timely and convenient manner. Mail delivery options have benefited people who are aging, people who live in rural areas, people who have significant professional or family obligations. Mail delivery, and particularly during a pandemic, must be protected. The administration must listen to patients and care providers about the importance of ensuring the Postal Service preserves all changes made and improves the speed and reliability of the mail. Congress must give the Postal Service the tools and funding necessary to adequately operate as they provide to move who needs access to their medications. Now I'd like to invite Marianne Tomaszek, my colleague at the Treatment Access Expansion Project. Marianne?
Thank you, Carl. If we can go to the next slide, great. For today, I'm going to go over three main asks that we have for Congress as it relates to COVID-19 and healthcare reform. We cannot ignore the immediate needs of people who are suffering because of the pandemic. And this includes funding for COVID-19 testing, tracing, and treatment, with a special attention to the disparities that we've already been seeing in communities of colors, as mentioned earlier, and on data collection to ensure that we have informed policies that address disparities seen among LGBT communities. We need hospitals to remain safe. We need workplaces to implement infection control plans. And we also need to ensure that people who don't have health insurance can get coverage through special enrollment periods and with enhanced financial help on the marketplace. Funding is also needed to strengthen unemployment benefits, housing assistance, food security, education, and childcare, because we already know that those types of support help people manage their health and stay well. So where are we now? The House passed the HEROES Act in May, but it went nowhere with the Senate. And yesterday, House Democrats released an updated version of the bill to reflect negotiation efforts, a HEROES Act 2.0, if you will. And so we need Congress to act on this bill now and keep people a priority. Next slide, please. Thank you. So we also need to make sure that COVID vaccine efforts are equitable and that vaccines are shown to be effective for all people. Vaccine trials must be representative of our diverse communities in regards to gender identity, sexual orientation, race and ethnicity, serostatus, and other characteristics. All vaccine trials must include people living with and impacted by HIV and should include communities of color who not only bear the burden of both the COVID-19 pandemic and the HIV epidemic, but represent a substantial percentage of people who are deemed essential workers and take on additional risks. So where are we now? We need our members of Congress to demand that the FDA Commissioner, Stephen Hahn, ensures that any COVID-19 vaccine is shown to be effective for all people living in the United States. And this accountability will make sure that the benefit of investing into the development and the production of a vaccine is shared by all. Next slide, please. And finally, we need to protect the gains that we made with healthcare reform and in expanding access to health insurance. The Affordable Care Act has helped us get more people insured and has lowered disparities seen in healthcare coverage. The law has strengthened consumer protections, including stopping insurers from denying coverage to people with pre-existing conditions or charging them more because of it. And thanks to the law, most health programs and activities are prohibited from discriminating against someone due to their race, color, national origin, age, disability, and sex. Recognizing that the Trump administration is doing their darndest to limit these protections, particularly sex-based protections, as they apply to transgender and gender non-binary people. So what's our congressional ask here? We need members of Congress to commit to protecting the gains that we have already made with the Affordable Care Act and hold HHS responsible for enforcing non-discrimination protections fully and robustly. Thank you to everyone for joining today, and I'll turn the theoretical mic back to Carl.
Thanks, Marianne, appreciate it. Well, thank you all for joining us for the first session of AIDSWatch Road to Resiliency.